Therapeutic diets. A therapeutic diet, it's kind of a qualitative and quantitative method to modify your regular balanced diet in order to achieve the treatment. Okay. Am I audible? Am I audible? Is everyone muted? So, therapeutic diet is a qualitative or quantity method of modifying your balanced diet or your regular diet so that your nutritional requirement or a treatment requirement can be met. Okay. Specifically for a health condition or to improve your health condition, to improve a disease condition, or if you are in a disease condition, you have to follow certain guidelines in your diet. Okay. So that becomes a therapeutic diet. So immunonutrition. So there are different types of therapeutic diets. Okay. Immunonutrition, the focus of immunonutrition is to make sure that your immunity is boosted. Okay. There are certain vitamins and certain macros and micros that you can include in your diet that can help with your immunity. Okay. So specifically like arginine, that is an amino acid, glutamine, omega-3 fatty acids, nucleotides. If these are in your nutrition, in your diet, your immunity improves. Okay. Arginine is an amino acid. It helps in maintaining a homeostasis for your body, that is making sure that the pH remains well balanced even when your body is stressed or there is a physical or emotional stress on you, but still the pH does not fluctuate in your body. It increases the macrophages in your body. Macrophages are your white blood cells that engulf, that swallow up all the unwanted foreign organisms, okay, and keep you healthy. And it is also, since it is an amino acid, it is a source of nitrogen as well. So that is how arginine helps. It can increase the production of nitric oxide in your body. Nitric oxide is important because it helps with vasodilation. That is, if you have high blood pressure, okay, vasodilation is important so that there is enough space for the blood to flow freely. Okay. And nucleotides, they are precursors of DNA and RNA, purines, okay, purine nucleotides and all. So supplementation can improve your cell mediated immunity. Glutamine, again, another non-essential amino acid, your body can synthesize this. But when you are stressed or when you are undergoing a multiple organ failure kind of a situation, at that point of time, glutamine, it becomes essential. Usually your body can synthesize glutamine, but when your body is undergoing some disease-based stress, okay, that time glutamine becomes essential. You have to supply it through your food. And omega-3 fatty acid, it has anti-inflammatory, antioxidant benefits for your overall health. So usually immunonutrition, you target that for people who have just now finished their surgery, who are in the post-operative wards, okay, post-surgery wards, okay, for them, and also people who have undergone some perfusions, uh, like intestinal perfusion, in which the intestine opens up and the contents of the intestine spills out, okay, damaging the nearby areas, okay. So in these conditions, immunonutrition is important. Is my voice clear to all? And usually we target immunonutrition for patients who are hospitalized, who have just followed up with their surgery, okay, who are recovering from their surgery, who may still have their stitches on. Okay, for those patients, immunonutrition is focused, means the nutrition, the food that you give them for these patients who are recovering from their surgery, arginine, glutamine, omega-3 fatty acid, nucleotides, okay, these should be there in their diet. That becomes a therapeutic diet for them. Regular routine hospital diets. Soon after surgery, solid food is not given to you. Okay. Just for an example, it starts with clear fluid diet. Okay. And slowly it goes towards full fluid diet, then semi-fluid diet or soft solid diet. Okay. And then slowly you finally reach the regular diet, regular balanced diet. Okay. But usually the first day after surgery, usually the patients are put on clear fluid diet, and slowly within 2 3 days, they reached to an area, to a stage where regular balanced diet in controlled portions they can be fed. Okay, so each one of these we'll see. So clear fluid diet, it can provide only 300 kilocalories. Okay, and we don't give any protein in this. In clear fluid diet, the focus is not protein. Do not give any protein in it. Usually, your focus is to give carbohydrates. Okay, and it is made up of only clear fluids. Okay, and they are clear fluid they are in fluid state even in room temperature. Clear broth, tea, strained juices. Okay, its consistency should be very watery, very close to water. That should be the consistency of clear fluid diet. During acute infections, inflammatory conditions, usually of your intestine, IBS and all, okay. Soon after completing the surgery, when you have moved to your uh, post-surgery ward, okay, it also ensures that the thirst is relieved. People soon after surgery and or who are hospitalized, when they feel thirsty, when they are put on clear fluid diet, it takes care of the thirst as well. It supplies tissues with water, and also it helps in removal of gas, flatulence. Okay, when surgery, after surgery, the doctor usually checks that if the patient has passed gas. Okay, so when the patient is put on clear fluid diet, it also ensures that the intestine starts moving and the gas is passed. Okay, milk is not given here in clear fluid diet, and not more than 1 day or 2 day. Okay, maximum 2 days you can put the patient on clear fluid diet. After that, slowly you have to increase the consistency of it. And there is no protein in clear fluid diet. Every 1 hour or 2 hour intervals, this can be followed. Then you have full fluid diet, which has around 35 gram of protein, 1200 kcal calories. That is full fluid diet. So it is frequently used as a bridge between solid food and liquid diet when you want to make that transition from uh, taking the patient away from a clear liquid diet, and slowly you want to introduce solid food. So full fluid diet is a transitional phase. Okay, all the food are again liquid at room temperature, and calories are also not too much. Okay, maximum 1200 kilocalories it can give. Full fluid diet will have protein. Okay, usually for a very short period of time it has to be given. At least 35 gram of protein you can add in full fluid diet. Milk is permitted here. Then we have soft diet, target of around 1500 kilocalories. 35 to 40 grams of protein is allowed here. It is very similar to regular diet. It has all the macros and micros, but it does not require much chewing. Okay, and it is very easy to digest. So podridges that you make, okay, that and all comes under soft diet. Jelly, podridges. But food that you have to avoid here is spicy food, desserts, this fried food, any raw fruits and vegetables and nuts that has to be avoided. Podridges, khichdis, okay, watery khichdis, dal chawal, okay, these can come under the soft diet. And it should not have harsh fiber. That's why raw fruits, vegetables, and nuts are avoided. And it's very low on fat, and it's not highly tempered or seasoned. You don't use too many spices here. So that is soft diet, and it's usually used during surgery, after surgery, patients who have been diagnosed with infections, digestive disorders, patients who have chewing problems and swallowing problems for them. Then finally coming to your regular normal diet, it should be easily digested. Maximum nourishment is should be attained through a regular normal diet, and it should have minimum effort in preparation. Okay, well balanced. 1800 to 2000 kilocalories should be the target. 42 to 45 grams of protein is permitted per day through regular normal diet. Patients who are ambulatory, which means patients who can move, walk around on their own, and also for patients who are bedridden, like multiple fractures and all, they cannot move, they're bedridden, but they can still digest regular normal diet. Okay. So here you can see in regular normal diet, total calorie, the target was 2000 at different times of the day. What kind of food and all you can include here? Mashed potatoes, cornflakes with milk, coconut, tender coconut water, rice, some curry, vegetable curry, soups. Okay. Easy to cook food, which does not require too much of effort. Okay. fat is around just to 25 grams, calcium 600 microgram, sodium limited 1200 microgram, 350 gram of carbohydrates per day, 45 grams of protein per day, and iron requirement 17 microgram. If you add supplements on this, all the other micronutrients and micro uh, minerals, okay, they can those requirements can also be met. Next, your nutritional support service in hospital, we call them as a healthcare team. Okay. So, nutritional support, when we say, it does not only mean that take care of the protein, calories, carbohydrates, control the fat intake. Okay. But you also have to provide other substrates that can heal the person. Okay. And how can you understand that your diet is healing your patient? If you are continuously monitoring the patient, okay, if you're continuously screening the patient, if there is a patient recovering, is the patient better than yesterday? So in a hospital setting, okay, nutritional support service, when we talk about nutritional support service, it's about a hospital setting, okay, not at home, because screening the patient on arrival, checking for their malnutrition, what kind of malnutrition they have, what deficiencies they have, taking their blood sample, taking their urine sample, giving it for analysis. These all will take care in a healthcare setup, not at home. Okay, so that's why nutritional support service is an extension of the hospital. Okay, the activities that you will take under the nutritional support service, it can take place only in a hospital setting. Okay, so you can see here, center of the service is always the patient. It's a patient-centered service. Okay. What patient likes, dislikes, what is best for the patient, what is the patient's opinion. Okay. What are the patient's choices, belief systems? All these things are kept in mind while making a nutritional choice. Okay. Doctors are also consulted for what is right and what is not right. Pharmacist for supplements, okay, dietitian to make a menu plan, nurse to make sure that timely food is given, okay, doctor will write what has to be given, okay, what should be included in the diet. Pharmacist will give the medicines, multivitamins, multimineral supplements that will come from the pharmacy. Dietitian will make a menu plan, okay, the food will come to the patient. The nurse has to ensure that the patient is eating on time. Okay, the nurse has to ensure that the patient got the food on time. Okay, and if the patient is on some feeding, tube feeding and all, NG tube feeding, the nurse has to make sure that whatever new calories this patient has to meet on a daily basis, that has been met by regular interval of feeding. Okay, so that's a nutritional support service. An example of how it functions. And usually, this nutritional support service is required by patients who are well nourished earlier, but right now they are undergoing some disease condition. They have some complications in recovery, so they require the nutritional support. But before that, before this complication, they were well nourished, they were healthy individuals. And other second case is for malnourished people, or people who have some severe deficiencies even before they got admitted to the hospital. And also for the patients who were found malnourished during admission. Okay, at the day of their admission to hospital, they were found malnourished. So in these three categories, nutritional support services required. Coming to special feeding methods. So enteral feeding and parenteral feeding. Just give me a moment. So enteral feeding, which means uh, using your different areas of your GI tract. Okay, mouth is the first area, the first option. Okay, if via mouth, if the person can't eat, okay, then other parts of the GI tract is used, okay, through tube feedings, okay, either directly through the nose. A tube will be inserted to the stomach. We call it nasogastric tube, okay, because nasogastric, from the nose it starts and it ends at the stomach. So nasogastric tube. And jejunostomy is done. Uostomy can be done, duodenostomy can be done. There are different types of ostomies done, openings done directly to access the GI tract, and there a tube is placed, and through that tube, direct feeding is given. Okay, so by any means of your gastrointestinal tract, we call it as enteral tube feeding. And then you have parenteral tube feeding, in which veins are used. Your GI tract is not used at all. Your veins, your blood vessels are used to put nutrition inside your body. Okay, so that's the difference between enteral and parenteral feeding. So here you can see diagrammatically how it is shown. In parenteral, you can see here there are two types of parenteral feeding, either through your peripheral veins, okay, or through a central vein, like your superior. Here you can see superior vena cava is used. Okay, superior vena cava and inferior vena cava are two large blood vessels, veins, okay, in the heart, that have direct access into the heart, superior vena cava and inferior vena cava. So usually when central line is placed, we try to access the superior vena cava. Okay, and peripheral veins, like when you get admitted in the hospital, when you are put on IV fluid and all, okay, they access the veins on your hands or arms, wherever it is possible to access the veins. So those are the peripheral veins. Okay, they are not the main veins, they are the periphery, they are on the peripheral part of your body, on the hands, arms and all. Okay, very far away from the central line of your body, so they are in the periphery. Okay, so peripheral veins are used. Okay, so these are the two main parenteral nutrition points, through the central vein and through the peripheral veins. Peripheral veins, it's your regular IV fluid. Central vein is a central, we place a central line in hospitals, we place a central line. It's an aseptic procedure. Okay, doctors has to be very cautious to directly access this main blood vessel. Okay, and then place a central line tube. Then you have enteral nutrition. So any point from your GI tract is used based on the condition of the patient. Okay, if the patient is able to chew the food, swallow the food, then obviously oral route is the first and the foremost option. If a mouth surgery, jaw surgery is done, okay, and the patient can't chew or swallow, then nasogastric tube. Through nose, a tube will enter till the tip of your stomach, in the till the fundus of your stomach. Okay, the top part is called the fundus of the stomach. That will end just 1 or 2 centimeter below your esophagus, where your esophagus ends. That is nasogastric tube. Okay, then you have your either it will end in the fundus, nasogastric tube, or it can end at your duodenum. Okay, so we call it nasoduodenal tube. Okay. If it ends in the stomach, tip of the stomach, nasogastric. If it ends at the duodenum, nasoduodenal. If it ends at the jejunum is the second part of your intestine. In small intestine is divided into three parts: duodenum, jejunum, ileum. Okay. So if it ends at the duodenum, nasoduodenal. If it ends at the jejunum, it goes further, quite further down. It becomes nasojejunal. Okay. So the all so through nose, if a tube is entering, it has three options to stop, either at the stomach, duodenum, or the jejunum. Okay, the length of the tube will determine where it has to stop. Next, um, if the nose also cannot be accessed, because see, either if the mouth through the mouth or through the nose, if a tube has to enter into the stomach, esophagus should be in a proper condition. Okay, if there is a big tumor in the esophagus which is blocking the esophagus completely, okay, nasogastric tube will not make sense, because if the tumor is growing, okay, it will press the nasogastric tube, it will damage the nasogastric tube, so it doesn't make sense. So in such cases, what you will do, you can directly make an opening, a surgical opening is done, ostomy, gastrostomy is done, tube is placed directly from outside into the stomach, that is gastrostomy. Okay, and the feed is directly given through this tube, it bypasses your entire esophagus. Okay, it directly goes into the stomach. Hydrolyzed food is given usually here. Okay, a semi-digested food is used here, and also jejunostomy. Another opening can, if stomach has some tumors or peptic ulcers, is stomach is also an area, along with esophagus. Stomach is also an area of concern. Okay, you cannot access the stomach. Then jejunostomy is the option. Opening is made. Jejunostomy tube is placed directly into the jejunum. Okay, and feeding is given through the jejunum. Okay. Again, partially digested, hydrolyzed food. Specific formula comes which you have to prepare, which the nurses have to prepare and feed the patient. Okay. So these are the different types of special feeding techniques. Is it clear to all? So types of food that is usually used in this special feeding techniques. So natural liquid food, easier, like skimmed milk. We don't use too much of toned milk here, because the flat globules, they can stick in the nasogastric tube. It can attract dust and all. So to avoid that, skimmed milk is used. Okay, it's easier. It's much more watered down. Skimmed milk is watered down, toned down, so it is easier to pass through the nasogastric tube. Eggs can be used, beaten eggs. Uh, the water of dal, after you cook dal or after you cook rice, cereals, and pulses, when you strain them, okay, the water that remains back, that can be used as a natural liquid food, because that has starch, it has carbohydrates. Whey water can be used here. After making paneer, when you separate the paneer from that water, the water that remains back is whey water. That can be used as well. Sugar syrups, molasses can be given. Vegetable oil can be given. Based on the calorie intake, protein intake, keeping that in mind. Nutrient dense food has to be given. Okay, even though it may look like just 500 ml of liquid food, but it should have enough nutrients. It should be packed with proteins, carbohydrates, vitamins, minerals. You can add multivitamin tablets, mash it properly, okay? Mix it properly, dissolve it into this liquid food, and then give it to the patient, okay? They cannot have taste it, okay? So the benefit of that medicines will be there. Then blenderized feeding. So here, food is cooked first and then it is blended well into a very thin liquid. Okay, it should be thin enough so that it can pass through the nasogastric tube. Okay, usually when you cook carrots, potatoes, or something, some vegetables, when you cook it and when you blend it, it is still thick. Okay, but you have to water it down, make it into a very thin, flowy liquid enough. Okay, it should be viscous enough to flow through the nasogastric tube. And approximately 1500 ml, 1.5 liters of water is added. That is the volume that you have to maintain, because this it is understood that 1500 ml should give 1500 kilocalories. So throughout the day, okay, at an equal interval, if you are completing, you have cooked a food, usually it's boiled vegetables and all, you have blended it well, mixed it with 1.5 liter of water, mixed it well, okay, and then throughout the day, if you're giving this food to the patient, it ensures that 1500 kilocalories the patient have received. Keeping in mind each ml provides 1 kilocalorie, and 50 gram of protein can be a target here. It's a little bit more costlier than the average hospital meal. You can also give probiotics and prebiotics in blend-rest meal. Then you have elemental diet, like substitutes, food supplementation and substitutes, like protein powder that you use. Okay, if anyone is using whey protein powder, plant-based protein powder, whatever protein powders you use, it's an elemental diet. Okay, like in Nutrilife, Herbalife, and all. If you are aware of these brands, they run on the principle of supplemental nutrition. Okay, they take away the cooking part of the food and they give you a packet. You have to mix it, drink it. That is your breakfast. Okay, so that is a substitution of food. That is elemental diet. Okay, anything that comes in packages that you have to just mix with water or milk and just um, substitute it with your meal, that becomes an elemental diet. Formulas usually. Okay, and they usually have very low fat content. It is already hydrolyzed, so it's very easy to digest. It takes care of all your vitamin requirement, mineral requirement. And they're better tolerated by the human gut as well. If it is prescribed by the doctor to be on elemental diet, because the patient may be on enteral tube. So as long as the patient is on enteral tube, follow the elemental diet. When the tube is taken out, when the patient can eat normally, the patient can be brought back to a normal diet. Okay. Then types of uh, feeding routines, okay, timings. Uh, you have a continuous method in which either through an infusion pump or through gravity, that is an IV. Okay. If you got admitted in a hospital, they have put you on glucose, like what we call as DNS, NS, okay, dextrose, normal saline, and all saline water. Okay, when you are put on this, we Am I audible? Is my screen visible? Am I audible? Is my screen visible? So in continuous feeding, like if you are put on an IV pump, okay, or infusion pump, it's electrically operated, okay. A big syringe is there, and electrically it is operated. Those and you can manage it how much ml should enter your veins in 1 minute or within 1 hour or throughout 24-day cycle, how much you have to finish. Electrically it is controlled, okay. Usually in hospital settings, in ICU settings and all, continuous feeding, enteral parenteral feeding takes through this IV feeding pump or through the IV fluid, okay. Then you have cyclic feeding. On and off time is there in 24 hours, okay. For example, morning 8 to afternoon 3, you will be put on infusion pump or you will be put on IV formula. Then after 3 it stops, the pump will be removed, okay. And then the next day again at 8 it will start till 3. That is cyclical, okay. There is an on and off time. From 24 hours, these many hours you will be on the pump. The remaining hours you are not on the pump, okay. That is cyclic. Then you have intermittent. Intermittent every 4 hours, okay. Usually 3 hours or 4 hours feeding will be given. Usually in nasogastric tube and all, we follow the intermittent way, okay. Every For 1 hour continuously a feeding is given, and then 3 hour break. Again on the fourth hour, feeding will start for 1 hour, okay, and then 3 hours break, okay. So at 9 a.m. if the feeding is given, the next feed will start at 12:30 or 1. Then at 4 it will start. Then at 8 it will start, like that, okay. That is intermittent feeding. Finally, the bolus method. Bolus method, large volume of food feeding is given in a very short span of time, okay. So at least 200 ml or 250 ml of food is given in one shot within 15 minutes. Within 15 minutes, using the nasogastric tube, 200, 500 ml of food would be given. And then after 2 hours, another shot of 200 ml. After 2 hours, another shot of 200 ml. So intermittent, you're using intermittent technique here, but the time is very less, not like you're spending 1 hour for one feeding. For within 15 minutes, you will give the feeding, but bolus of big volume of feed will be given in that 15 minutes. Okay. So these are the different types of food feeding methods. Then we have total parenteral nutrition. Uh, Here, the patient does not take anything through mouth. All the nutrients required for the patient's survival is given through parenteral route. Okay. TPN is you will use central line for that, not the peripheral veins. Central line is usually used for TPN. And directly into the vein, because why central vein is used? The vein is big, okay? When such a big dose of all essential nutrients are coming, it's better that it gets mixed with the blood in the heart quickly, and heart pumps the blood with all this nutrition immediately throughout the body. For this purpose, central line is chosen for total parenteral nutrition. When it comes to peripheral nutrition, or partial parenteral nutrition, your peripheral veins, small veins, can be used, where only 30 to 50% of your daily requirements you require through these parenteral route, but otherwise you are fit to eat normally or be on nasogastric tube and all. Okay. So other 50% or other 70% of the nutrients are met through other modes of feeding methods, either oral method or nasogastric method, jejunostomy, gastrostomy. Okay, these methods will be used. The remaining part, the remaining 30% or 50% of the nutrition, that is the responsibility of the partial parental nutrition. So where normal IV therapy is used, okay, intravenous therapy is used. So there are a lot of formulas under this topic that is only for clinical purposes. You don't have to study that. TPN is also called hyperalimentation, because central parental nutrition or hyperalimentation, because all the nutrients are supplied in excess of needs. What the actual needs are of the patient, little bit higher than that is given through the TPN. Large amount of nutrients in a hypertonic solution is supplied directly into the superior vena cava. Okay, the central line catheter is placed in the superior vena cava. It's a big vein that directly accesses your heart. Okay, so whatever nutrients are going, it's directly through this vein. It is directly going into your heart, and the heart will because it large volume of nutrients, when it is coming together in a hypertonic solution. Okay, if you give this solution, hypertonic solution, through the normal peripheral veins, it can cause some disaster, it can cause some health concerns. Okay, so it's better uh, it has enough surface area to get quickly mixed with your high blood flow in the heart, and get mixed quickly with the when the heart pumps the blood, and it is pumped out of the heart immediately. Okay. Complications are also there with total parenteral nutrition. Infection, it is very common. We call it central line associated bloodstream infection. CLABSI, central line associated bloodstream infections. Okay, that's a common hospital acquired infection. Okay, healthcare associated infection. That is very common because you are placing the central line catheter on the patient for some days. And if the patient is not taking good care of that catheter, microbes can enter the patient's direct blood system. Okay. Air embolism can take place. Like if you are not very careful with your central line, small uh, small pockets of air can enter into the nutrients, and it can travel through the blood circulation, and that's a complication. If it gets stuck in the lungs, it can lead to immediate death. Okay. Hyperglycemia, hypoglycemia, too much of blood sugar levels, too less of blood sugar levels, electrolyte imbalances, fluid balance disturbance, acid base disturbance, because remember, hypertonic solution, okay, a very concentrated solution is entering directly into one of the chambers of your heart. It's entering into your right atrium, and from there it is going to the right ventricle, and from there it is being pumped out of the heart through the pulmonary artery. Okay. So like that. So a lot of imbalances, electrolyte imbalance, fluid imbalance will take place because a concentrated hypertonic solution is entering your body. Okay. Then we have the refeeding syndrome. It's very common when a patient is recovering from malnutrition. Okay, refeeding syndrome happens. It's a complication of enteral feeding or parenteral feeding when a severely malnourished patient is admitted in the hospital and you are giving them the nutritional therapy. Okay, but when there is a sudden shift, anabolism is stimulated. Okay, when there is a glucose load, now till yesterday the patient was malnourished, the patient didn't had any access to food. Now there is an influx of a lot of nutrients in the patient's body. Okay, the patient's body was in a catabolism state yesterday, till yesterday. Catabolism means patient's own body was breaking down its muscle protein, its own fat deposits, its own glycogen stores for survival. That was the state till yesterday for the patient, catabolism. Now the nutrients have started reaching the patient's body. Once the patient was admitted in hospital, nutrition started reaching the patient's body. Now from catabolism to anabolism, the shift is happening. Okay, so the body has started the metabolism of carbohydrates. The body has started preparing more proteins out of the food that the patient is receiving. Okay, now immediately all the cells are awake. They are taking up glucose, they're taking up potassium, magnesium, phosphate. Okay, everything, there is an increased uptake at the cellular level. Okay, and automatically what happens, till yesterday the cells were uh, they were deficient in all these micro minerals and vitamins. Right now there is a sudden increased uptake. Okay, at a cellular level, each and every cells of different systems in your body, immediately they are grabbing onto these vitamins and minerals as much as possible. So at a various systemic level the patient will suffer. Okay, at neurological level the patient immediately uh, feels confused. Okay, there could be seizures or coma because yesterday the brain cell was not having carbohydrates. Now suddenly there is a flood of carbohydrates. Okay, so there could be some dearrangement happening, electrolyte dearrangement happening at the neurological level. That would lead to some symptoms. Cardiac arrest can take place. Okay, cardiac overload can take place. At pulmonary, that is your respiratory system, the patient may not be able to breathe properly. Okay, the skeletal muscles, or there is a fluid overload because the patient was dehydrated as well. So, along with malnutrition, the patient was dehydrated. Now there is a sudden overload of fluid into the patient's body. Okay, that could lead to respiratory issues. Renal output, kidneys have to work extensively right now. Okay, there is an increased amount of water, sodium, electrolytes, potassium. The kidneys have to function immediately, and more it has to work more. That could lead to renal failure. Okay, at in the blood as well, immediately when there is a influx of hypertonic solution into your blood, there would be pH disbalances. Okay, hemostasis disbalances, electrolyte disbalances will take place in your blood. So that is a refeeding syndrome. You're trying to help the patient recover, but the way how the patient's body may respond, you may not have a complete control over it. That is the refeeding syndrome. Okay, it's a complication of this parenteral feeding and enteral feeding, especially when you are dealing with a malnourished patient. Coming to nutrition and wound healing, when there is a wound, or when even in case of burns, okay, burns are also wound. These are the nutritional requirement. Protein, 1.5 gram of protein intake increases when you are wounded, or when your body requires wound healing, protein requirement increases. Okay, even when even though in this situation the patient is sedentary, patient is in complete bed rest. Okay, but still the protein requirement is 1.5 gram per kg body weight. So protein requirement increases. Energy requirement 30 to 35 kilocalories per day. Okay. Energy requirement also increases, but more from fat and carbohydrate. Fluid intake has to be increased 30 to 35 ml. The body has to be hydrated well, because a dehydrated body will not heal properly. When there is dehydration, wound will not heal properly. And all the micronutrients like zinc, vitamin C, okay, these supplementations are required for quick wound healing, especially vitamin C, vitamin A for cell turnover, omega-3 fatty acid. Okay, these are required for quick wound healing. Pre and post-operative nutrition, like when you're preparing a patient for surgery, before surgery, what should be the nutrition? Make sure the patient is well hydrated. Okay, because nutritional level does not matter much before surgery, but hydration level matters. Okay, avoid excessive fasting. Okay, because nil per oral the doctor will recommend. At from what time onwards the patient should not eat anything from mouth. Okay, they can drink water, but apart from that, nil per oral, nothing solid food should not be taken via mouth. Okay, usually 8 hours before surgery, this has to be practiced, because you don't want the patient to aspirate while on the operation table. Okay, aspiration means when the patient is under anesthesia, what if there is some contents in the patient's stomach that can go into the patient's windpipe. Okay, because the patient is in the lying down stage. Okay, so stomach contents can seep out through the esophagus and get into the windpipe, and it can cause pneumonia. It can cause some complications during surgery. So that's why nil per oral is recommended. Nothing through mouth 8 hours before the surgery is allowed. Okay, and fluid also 2 hours before surgery you have to stop taking the fluid. Only 2 hours before the surgery you are allowed to take, and that 2 hours between the surgery and your last glass of water, nothing should go through your mouth. During the operation, that is the part of the anesthesiologist and surgeon and the nurses in the operation theater. They will take care of the fluid balance through IV therapy, parenteral and central line and all. They will take care of the fluid balance. They will continuously monitor the blood saturation level. Okay. If a blood loss is indicated in the surgery, they are ready with enough amount of blood bags. Okay, to mitigate the blood loss during surgery. And after surgery, when the patient is back into the post-operative ward, uh, as soon as possible, oral intake is encouraged, because you want, once the uh, body is waking up from anesthesia, okay, it's not that your consciousness is alone waking up from anesthesia, even your internal organs, okay, like intestine, they are also waking up after anesthesia. So oral intake is encouraged early, because when you swallow something, peristalsis movement will start. That is very important. Okay. So as much as possible, you will not keep the patient on long time on clear fluid diet or only fluid diet. As soon as possible, solid diet within 2-3 days, the patient has to start. Okay. After surgery. That is the care given. The nutritional support during burns. In burns cases, burn centers are there, okay, and burns intensive care units are there. They will take care of the nutritional support, okay, because there is a lot of metabolic abnormalities the patient has to endure when they have suffered from burns. Depends on the degree of burns as well: first degree, second degree, third degree, fourth degree. Okay, they have a lot of stress. The body is under a tremendous stress. The body is under hypermetabolism. Okay, so the nutrition also has to keep up with this hypermetabolism, because the body goes into a state of catabolism. Body breaks down everything to survive. So your nutrition has to keep up with this hypermetabolism. Okay, and wound healing is also another main thing. So protein requirement has to match, because from the burnt area, whichever body part is burnt, from that open burns, the patient is continuously losing nitrogen. Okay, and proteins has to be given back into the patient's body to maintain that nitrogen balance. Okay, so nitrogen balance has to be maintained uh, to uh, to match the loss. Okay, and nutritional support is completely dependent on how much area the patient has burnt. TBSA is total body surface area. TBSA, total body surface area that is burnt, the percent of the body surface area that is burnt. Based on that, nutritional support is calculated by the doctors. Okay, they calculate it, and then they provide how much IV fluid should go on throughout the 24 hours, what food has to be given. Okay, feeding will immediately begin from the day of burns injury or within 24 to 74 hours of burns injury. Enteral route is preferred usually. Anti-jejunal feedings also work best for burns patients, because there is very low risk of aspiration. If you're putting something directly into the intestine, there is no chance that it will go back into the stomach and get into the trachea. Okay, so to lower the risk of aspiration, jejunal feedings work better. Okay, also the patient will not have the appetite to eat after burns. Okay, so enteral feedings work better for burns patients. That's about today's session. If you have any queries, you can mention in the chat box.